So, Mr. Lucas, I have your notes here, but I wonder if you could tell me in your own words what's brought you here today.
Well, towards the end of last year, I had to take some time off work because I was absolutely exhausted. I didn't really know why. It was a level of tiredness I hadn't felt before. Then, one morning, I found I had slightly swollen legs. It was really alarming because it literally happened overnight. It wasn't like anything I'd experienced before. And it wasn't the only thing that was going on either. I had this strange tingling sensation in my wrist and some of my fingers, though, no actual pain.
I see. And were there any other symptoms?
Well, I used to love my food. In fact, one of my passions is cooking for friends and family. But I was suffering from a complete loss of appetite.
I see.
It wasn't like me at all. Generally, I didn't feel that well, and I wasn't in the mood for doing anything very much. Occasionally, I'd get short of breath, too. This could happen even when I wasn't doing any exercise or anything. A few times I thought I noticed an irregular heartbeat. I was very worried about that.
Okay, so when you saw your GP, he wasn't sure what the problem was?
No, it was such a strange mixture of symptoms, though he reckoned there might be some problem with my kidneys. He said I needed to go and have some tests at the hospital, and that made me even more anxious, to be honest. Anyway, I had a CT scan and a biopsy to check things out. This showed that I'd got these protein deposits in my kidneys. I can't remember the name, though I was told stuff like that, actually.
Right, it's called an amyloid, but don't worry about the medical terms.
Okay.
Anyway, at this point, you had some other things checked out?
Yes. Fortunately, the blood tests I had didn't find the same build-up of protein in the heart. That was a relief, because apparently that's much more difficult to treat.
Yes, indeed, that's true. And I understand that it was confirmed that your condition was unrelated to anything else.
I was told that sometimes what I've got is a sign of a type of bone cancer, but I was given the all clear as far as that was concerned.
Okay. Now, as soon as the diagnosis was made, you were given some detailed advice regarding your diet. Is that right?
Yes, I had to reduce my salt intake more or less immediately. I found it a bit hard at first. Having to avoid a lot of recipes that I normally enjoy and having to think carefully about everything I ate and how much. And then, as you know, I had my first session of chemotherapy last month. It wasn't pleasant, but at least it seemed to be reasonably successful. I was told that it wouldn't be enough on its own, though, that I had to take steroids at the same time. It's been a difficult time. I felt really ill after this initial round of treatment, and it was some time before I was back on my feet.
Well, I believe my colleague has discussed with you the fact that we need to run regular tests to check the levels of amyloid deposits in your kidneys.
Yeah.
The problem can recur, but hopefully it's under control at the moment.
Oh, that's good news. I know there's probably no actual cure for this condition, but your colleague talked about maybe having a stem cell transplant in the future. He explained to me in detail the ins and outs of the treatment. I was relieved that no dialysis would be necessary. Fortunately, it seems the problem has been caught early enough to avoid that.
No, you haven't had anything like complete kidney failure, though. We need to keep a careful eye on this. So what we need to talk about today, Mr. Lucas, is some further medication for you then.
Well, Mr. Lee, first I need to get an overview of how your condition has developed. Can you just describe for me the initial symptoms?
Well, it's a long story and it took ages to get a diagnosis. It's been very difficult to cope with.
I totally understand your frustration.
There were quite a few symptoms, but I didn't connect them all at first. I had 3 or 4 separate lots of mouth ulcers in the space of less than a year. They were quite painful and I couldn't eat properly.
Okay.
I've occasionally had them in the past, but not as numerous and frequent as this. Then in June last year, I suffered from this really bad inflammation of both eyes. I went along to my optician and he gave me something for it and said it would settle down.
And did it?
Actually, yes. That's been one of the weird things about all my symptoms. They flare up and then sort of disappear after a while. And I rarely had all the symptoms going at the same time, thank goodness. Once or twice I came out in spots, and it brought back unhappy memories of acne when I was a teenager. Around the same time I noticed these slight skin lesions on my leg. The skin was red and felt very tender. Even after the swelling had gone down, the skin looked odd, quite discoloured.
Okay.
And it still is. I can show you.
Were there any other symptoms?
Well, I started getting these awful headaches. One of them really knocked me flat for a whole day.
Okay.
The only other thing was a definite stiffness in the joints. My mother had arthritis, so I thought I had the same problem too, but again, like a lot of the other stuff I'm telling you, it sort of went away without any treatment. At this stage, I was sure it was my diet that was causing all these problems and thought some food types might be triggering some of the symptoms.
And what did your GP say when you saw him?
He ordered various blood and urine tests, and at one point he thought I might have contracted Lyme disease because I do enjoy my walks in the countryside, and a couple of the symptoms seemed similar. The test didn't point to anything.
Right.
I saw a different doctor and he speculated about possible lupus and explained what it was. He wasn't totally convinced, though. The lack of certainty was upsetting and just made matters worse.
And then you had further tests?
Yeah, the diagnosis became more definite when they did a pathogy test. I had such a strong reaction that it seemed to be like the final piece in the jigsaw puzzle.
Right. And then you were referred here?
Yes, and I've had to see various specialists to deal with the different symptoms. I was given some immunosuppressants straight away, though they did warn me that there was the possibility of side effects. I know it can be like that with almost every drug, but I didn't expect to suffer the way I did. Basically, I had a lot of abdominal pain, and would you believe it, some of my hair started to drop out.
Right. So that treatment was discontinued?
Yes, I was told that biological therapies would probably be more effective. Is that right? I haven't reacted in the same way to this new treatment, at least not so far. There have certainly been no strange side effects. I feel a little better overall.
Okay. Now, I believe you're seeing the ophthalmologist this morning.
Yeah, she's going to give me some corticosteroid eye drops. And the other urgent problem right now is getting to grips with the headaches. Your colleagues have put me on beta blockers. I'm hoping they'll prevent these headaches developing in the first place.
Yes, they should work well. Now, we just need to discuss your recurring joint pain and see what we can do to ease the...
Okay, now some feedback on how you've been taking blood pressure on the ward today. Before you report a reading that seems outside the normal range, check that the cuff you're using isn't too small, as this can push up the reading. I'm pleased it's not been an issue for you, judging by what I've observed. However, the patient must be in a position that's comfortable, and sometimes you're not quite managing that. To be more precise, please ensure in future that both the back and arm are supported, with the upper arm at the same level as the heart. You all seem to have taken on board that quite a few patients will be nervous when they're with medical staff, and this may result in significantly higher blood pressure. So it was good to see you weren't too alarmed by some of the higher readings today.
Now, Mr. Mitchell in bed 17 has had a hip replacement and has been assessed as being at high risk of developing deep vein thrombosis. The fitting of the compression stocking today was fine initially, though later he complained about it being slightly uncomfortable to wear.
Okay, not much we can do about that, I guess. What anticoagulant medication is he on?
That's written down here. He's just had his latest dose, so requires nothing more until 11 o'clock. I'd go and have a chat straight away about how vital it is for him to walk around, or at least flex his muscles every half hour or so.
Okay, I was told yesterday he can be reluctant to get moving.
Well, I'm sure he can be persuaded. He is taking plenty of fluids, though, but please continue to monitor his intake during your shift. Thanks.
So, Mr. Clark, you'll need to keep the cast dry, which means covering it with a plastic bag when taking a shower. I'm sure you'll manage.
If the cast does get wet, I can use a hairdryer, can't I?
Yes, put it on a cool setting, though. One other thing, it's easy to forget to exercise the shoulder and the elbow. Don't sit all day like a statue.
Right. And it's not normal to feel any tingling or numbness.
It's unlikely to happen, but inform us as soon as possible if it does. After a day or two, some people can start to feel the cast is too tight or too loose. Again, if that's an issue, you should let us know.
Okay, so you can adjust it?
Actually, we can replace the cast if there's any discomfort.
Ah.
Okay, that completes your annual asthma review. We've discussed the possibility of a slight change to your technique with your inhaler, but having seen you demonstrate what you do, I think I'm satisfied things are probably fine.
Oh, right. And you think I need to watch my symptoms more, right?
Well, there seem to be a few new triggers for your asthma. It's a matter of writing down details about when and where you have an unexpected asthma attack and what happens exactly.
Okay.
It'll help us identify what the cause is.
You mentioned going to the hospital again to check out how well my lungs are working. What's it called? The peak flow test?
You might need to do that again at some point, yes. For now, it can wait.
Right. Mrs. Taylor is a little upset, and so it would be good if you could talk to her a bit more before she goes.
Sure. She was complaining about the dilating eye drops I put in before you examined her, so I hope things settled down.
Yes, and she won't need to take any home with her. I think the issue going forward is the treatment plan. She's anxious about having injections in the eye for her macular degeneration. I've explained it's not painful and there's a high success rate, so don't feel you need to go through all that again, at least not today.
Okay.
She could do with some information about counselling services, though.
Okay, I'll give her the leaflets. Also, the one for support groups in the area. She sounds as if she may need something like that.
Thanks.
Before changing the dressing, if there are any particular instructions regarding how to deal with Mrs. Harris or the ulcer, you'll be given them at the start of the shift. You won't ever have to access her records yourself and scroll through everything. There's an equipment checklist here with the type of cleaning solution and forceps you need, so you'll know that off by heart. You'll see that a face mask isn't essential, though some nurses prefer to have one. As you know very well, you should chat to Mrs. Harris very briefly about what you'll be doing, even when she gets familiar with the routine. Now, please take great care in recording the condition of the skin surrounding the wound, plus the presence of any sort of inflammation, discoloration, or odor. This assessment has got to be thorough. Then get her in a position that's comfortable for her, and you can begin.
Okay. Good morning. I'm Tim Rushton, and I'd like to talk to you about rehabilitation programs for patients who've had heart attacks and undergone surgery. A patient may, for example, have had stents inserted to widen their arteries, and this solves an immediate problem without guaranteeing their long-term health. The importance of taking the drugs that have been prescribed is undeniable, and non-compliance is seldom an issue. But the patient's ability to improve their prognosis through the choices they make is sometimes not fully appreciated. If a patient takes exercise and makes dietary changes, they're more likely to lose weight, reduce their blood pressure, and possibly control their level of cholesterol. The evidence available suggests that once someone's going beyond moderate exertion and can sustain such effort for a longer period, then the vascular system and muscles adapt and strengthen. Basically, the cardiovascular system starts to perform more efficiently. We actually have some pathological reversal, and that's an extraordinarily positive message to give patients. What I find shocking is that annually thousands of people are choosing not to do potentially life-saving cardiac rehabilitation therapy. Joining a rehabilitation program after a heart attack can cut an individual's risk of dying in the next year by as much as a fifth, and will significantly reduce the probability of having to be readmitted to hospital with a recurrence of heart problems. Many people opting out of rehabilitation seem to be well informed about these facts and figures, and yet research shows that even if a GP refers them and makes the process of signing up easy, patients may decline an offer made to them or drop out of the program quite soon. It seems that many patients are convinced it's dangerous for them to do too much exercise in a rehabilitation program in case it puts them back in hospital with a second heart attack. I regret to say patients are picking up mixed messages from the media. The benefits of exercise are certainly discussed, but there are also warnings about embarking on exercise programs, especially for those who have done little previously. The reality is that the chances of having a cardiac event during exercises done as part of a rehabilitation program are extremely slim. This is mainly a direct result of the exercises having a clear structure, with a warm-up stage beforehand and a gradual step-by-step cooling down period at the end. What about other reasons for people not doing rehabilitation therapy? Let's consider the case of one. I'll call her Lucy. The idea of exercising in what she assumed would be a gym, or a setting closely resembling one, made her feel uneasy. Lucy felt that, like many people, she wasn't exactly sporty, and so would feel out of place there. She expected the group to be largely male, and with good reason. Significantly more men than women have heart attacks, but this imbalance didn't bother her much. She thought the instructors would probably be fairly strict, which she felt she could cope with. However, Lucy still didn't show up for the first session. But when she overcame her dislike of being in a gym, she found it more enjoyable than she imagined, and stuck with it. Let's consider how rehabilitation programs could be better in the future. Firstly, most programs are based on group-based exercises, and this may not appeal to everyone. There's also evidence that individuals from areas of greater social deprivation are less likely to participate. It seems to me that health professionals can't always blame the patients for not taking up offers. Sometimes what's available has little appeal. Consideration should be given to running programs based more on what individuals can do in the privacy of their homes. Greater resources could also be put into setting up online programs. In general, more can be done in tailoring programs to suit a wider range of individuals. Finally, I'd like to tell you about one of my own patients. Let's call him Michael, who was diagnosed with coronary artery disease at the age of 52. After surgery, he totally lacked confidence. Every little ache and pain he experienced made him think that there was a new problem with his heart, and this held him back from resuming normal physical activity, let alone taking on a rehabilitation program. He was booked on a cardiac rehabilitation program involving 8 weeks of closely monitored exercise, but equally importantly, he had sessions with a clinical psychologist to help manage the anxiety he was feeling. Now, he claims to be in a better place emotionally than he was before his heart attack. Rehabilitation isn't just about building up physical strength and fitness. There are other dimensions.
Good morning. My name's Veronica Schulman, and I'm a gastroenterologist. I'd like to talk to you today about irritable bowel syndrome, or IBS. As many as 1 in 5 of the UK adult population are affected by IBS to some degree, and it's been the focus of much research in recent years. It's typical for those suffering from the condition to report frequent diarrhea or constipation, or a mixture of both. They also experience abdominal bloating and pain. I'm always surprised more people don't suffer from IBS because many of us lead such chaotic, highly pressured lives and are often unable to maintain regular eating habits, which seems to aggravate the condition. It's difficult to treat, with no single medicine consistently and reliably resolving the symptoms in all cases. To add to the problem, a small number of people have what's called refractory IBS. That's IBS that hasn't responded to the normal first-line treatments. Unlike today, in the past, IBS symptoms were easily confused with other conditions, and the difficulty in making a definite diagnosis increased the uncertainty and therefore the suffering of many patients. So what about making an accurate diagnosis of the condition nowadays? Well, there's a stool test which rules out infection, while an endoscopy will eliminate the possibility of inflammatory diseases such as Crohn's disease and ulcerative colitis, which share some symptoms with IBS. a comprehensive history, and special laboratory tests will in most cases prove that someone has IBS. The result is that the GP and the patient can trust in the accuracy of the diagnosis, and less time is wasted before starting an appropriate treatment. So next, I'll talk a little about how I like to treat my own IBS patients. It's been known for some time that diet is crucial, but opinions have varied considerably on which foods trigger the condition. I've become particularly interested in a group of starches and sugars, which many patients struggle to digest, and which are clearly linked to IBS symptoms. These starches and sugars are present in some grains, vegetables, and dairy products. Interestingly, they are also contained within one group of artificial sweeteners added to some food and occur naturally in certain fruits. I start my treatment of an IBS patient by putting them on a strict diet for up to 6 weeks. During this time, all foods with the starches and sugars we've identified as problematic are excluded, and then slowly they are reintroduced one at a time to see if there's an adverse reaction. Common problem foods include wheat, onion, garlic, and broccoli. Up to 75% of patients improve to some degree when they're in the initial exclusion stage. Sugars and starches are found in so many different foods, and it's unlikely that patients will be sensitive to all of them. In fact, it may only be 2 or 3. So, how do patients react to this approach? I'll tell you about a patient called Matt, who lived in fear of stomach pain. He'd almost become frightened to eat anything. He'd endured it for several years and had seen many doctors, and even been willing to experiment with alternative medicine. But none of the treatments had provided much relief. Like many IBS sufferers I meet, he was overwhelmed by the amount of information about nutrition that was available. But he had serious doubts about the very many claims made by companies promoting particular diets as miracle cures. Matt still believed his condition could at least be controlled and desperately wanted to try something that had solid research behind it. He was impressed by the steady and structured methods I rely on. Before seeing me, another patient I'll call Sophie had been told to cut out dairy produce from her diet, but she found it hard to sustain and her symptoms continued, although they were intermittent. By the time she was referred to me, Sophie had become confused about whether dairy was really causing her problems. Her IBS was getting worse because she was so anxious. When she followed my method, she was able to discover precisely which foods were triggering her symptoms, which in her case included beetroot, apples, and oranges, all of which she particularly liked, and so was initially reluctant to give up. However, she knew there was no real alternative, and she's now made more or less a full recovery. Patients with IBS are often deeply concerned about the basic health of their bowel and can mistakenly think that it isn't normal in some way. I often have to reassure them that their bowel is just very sensitive and that it won't suffer any long-term damage. If a patient usually follows a diet which controls their symptoms, and one day they indulge themselves by eating something they shouldn't and get some symptoms, that's not going to do much harm. The diet can be resumed and the symptoms will resolve themselves.